Good afternoon, everyone, and welcome to the spring edition of UHN Foundation's Behind the Scenes Lecture Series. My name is Christy Spencer, and I'm the Senior Director of Stewardship at UHN Foundation. I am thrilled to be your MC today, and I am very glad to be spending the next hour with you. UHN Foundation is committed to providing you with the most up-to-date information about our healthcare system, and this afternoon's presentation is a way for us to thank you, our incredible donors, for your continued generosity and support. Our behind-the-scenes lectures give you a snapshot of some of the amazing work that is happening at our hospitals, and today's presentation is no exception. Today, we are incredibly fortunate to welcome Dr. Jessica Liu, Division Head of General Internal Medicine and Geriatrics at UHN and Sinai Health System. The General Internal Medicine Program, or GIM, at UHN provides critical medical care to those with complex medical conditions, many of whom come from under-resourced and underserved communities. It's likely that at some point in a patient's journey, they will require comprehensive care by an internal medicine specialist. UHN's GIM physicians are clinicians, teachers, and researchers based at two sister sites, Toronto Western Hospital and Toronto General Hospital. Both of these sites are dedicated to research and education, each with its own specialized knowledge that contributes to outstanding care. GIM physicians handle diverse issues in our ever-evolving healthcare environment, often navigating situations without clear guidelines or established rules. Over the past few years, the demands on the GIM team have grown exponentially to accommodate increasing patient needs. GIM physicians are at the forefront in developing innovative care models aimed at creating system-wide improvements in clinical programs to better serve all UHN patients. When the COVID-19 pandemic hit, GIM physicians swiftly became experts in real time and mobilized to the hospital front lines to create dedicated acute inpatient COVID-19 wards. The majority of UHN's COVID-19 patients, over 70% of them, were cared for on GIM floors. As creative problem solvers, GIM physicians were perfectly equipped and uniquely prepared to care for COVID-19 patients, and we are so incredibly grateful for that, and of course, for them. In recent years, the creation of the TGH Health Quality and Innovation Hub has brought together a collaborative network of GIM scholars working together to measure and improve healthcare quality for patients in and out of hospital. The aim of the Innovation Hub is to create, study, and implement meaningful change in today's healthcare system. This afternoon, Dr. Liu will be able to tell you more about the critical work the GIM team is doing every day to ensure that no patient is left behind. So as our conversation unfolds today, if a question comes to mind, we'd love to hear from you. We invite you to submit your questions to Dr. Liu via Slido. There should be a link just below the screen to get to our Slido page, and we'll dedicate the last portion of this event to your questions. It now gives me great pleasure to officially introduce Dr. Jessica Liu. As I previously mentioned, Dr. Liu is an internal medicine physician at UHN. She is the Division Head of General Internal Medicine and Geriatrics at UHN and Sinai Health System, and she is also an Associate Professor of Medicine at the University of Toronto. Dr. Liu is a forward-thinking leader with a strong vision for the future of GIM. She is a committed physician who deals with complex medical cases and a respected researcher dedicated to creating system-wide improvements and new models of care. We are thrilled that she could be here this afternoon, especially after being on call all week, to give us an overview of the GIM program, how it was impacted by COVID, and what her plans for the division's future are. Dr. Liu, welcome, and over to you.
Thank you, Christy. I'm Jess Liu, and I'm the Division Head of Internal Medicine at UHN, and I'm very pleased to be here today. So distilling what my specialty does into one sentence is a challenge for me, but internal medicine physicians are specialists in the diagnosis and management of complex multi-system diseases. We're commonly known as general internal medicine or just internal medicine or GIM, so you might hear me use all of these terms today. So to start, our team is comprised of 30 physicians working at two sites, Toronto Western Hospital and Toronto General Hospital. And then if I could introduce myself a bit more, in addition to being the division head and an internal medicine physician, I'm an assistant professor and a healthcare quality researcher. I'm also a wife. That's my husband, Matthew. and a mother. I'm very lucky to have the family that I have. These are my twin girls, Emerson and Isabella. And I thought I'd start by telling you a little about what my typical workday is like and how it starts. Like Christy said, I just got off 2 weeks of inpatient service yesterday, where I cared for around 25 patients at a time admitted under me for 7 days a week, 24 hours a day. And so this talk came at a perfect time. So I start work typically at around 7:15 in the morning. A little rushed to leave because I'm sure you can imagine what mornings look like at my house with 2 6-year-olds. But I'm also rushing because every morning I'm on service, I have new patients to see. Yesterday, in addition to the 20 patients I had admitted under me on the wards, I had 5 brand new sick patients waiting for me. So I walk to work, sipping a coffee, I change into scrubs, and I head first to the emergency department where I meet my new patients. Why the emergency department? Because the vast majority of the care we provide is unplanned care, meaning that every single patient is an emergency admission to hospital and they're sick. They were brought in by 911 or sent in by another physician because they were worried about them. And so I never know how many new patients I'm going to meet on any given morning I'm on call, because by definition, unplanned care is unexpected. Our patients are sick and they need our help immediately. So my first patient of the day is Mr. A 59-year-old engineer. He collapsed at work, hit his head on a table on his way down. But even before the fall, he seemed confused to his coworkers, which is not usual for him. Paramedics who brought him in noted low blood pressure, a fever, and yellow skin and eyes. His abdomen was severely distended. He vomited in the ambulance and it looked like coffee grounds. He had low oxygen levels. And people at work said he was under a lot of stress at work and had recently separated from his wife. But the emergency physicians asked my team to see for jaundice not yet diagnosed, or jaundice NYD. So we learned that he was doing well in a high stress job previously. He only took 3 or 4 medications for things like sleep, his prostate, and shoulder pain. He also had high blood pressure. He didn't smoke and he didn't drink alcohol. He was confused. He knew who he was. He could answer questions, but it was hard to keep him talking. He didn't remember what happened. Thankfully, the ED physician had done a CT scan of his head and there was no sign of bleeding. But his lab work was very abnormal. His liver was inflamed. His kidneys were shutting down. He was anemic. His blood work suggested he was at increased risk of bleeding. And so we ordered a chest x-ray, an EKG, and then we took the bedside ultrasound machine to his abdomen where we found fluid in his belly, where fluid normally shouldn't be. And we call that ascites. We did a bedside procedure called a paracentesis, where with a needle at the bedside, I drained 3 liters of blood-tinged yellow fluid from the bedside, or from the patient's abdomen. So this was suspected to be acute liver failure, complicated by potentially a bleed from his esophagus and an abdominal infection. And all of this was causing concurrent kidney failure. We started antibiotics through an intravenous line. We transfused red blood cells, and he was admitted to our internal medicine wards for ongoing care and treatment. So next, due to overcrowding, I saw the second patient in the emergency room hallway. She was in her 40s. She's a busy teacher, and she was a mom to an 8 and 10-year-old, active on no medications, which is very unusual for me because our average patient on internal medicine is easily on 20 medications or more. Her exercise tolerance was decreasing every day, and really that was her only symptom. It got really bad one day, so she went to a walk-in clinic who ordered a chest x-ray. And after the results, they called her immediately and told her to go straight to the emergency department. She had fluid almost entirely around one lung and required oxygen support. We did a CAT scan of her chest. We did a CAT scan of her abdomen, and we found large masses in her liver, her lymph nodes, and even in her lungs. And the lungs themselves showed scattered little tiny clumps of cells throughout, highly suspicious for metastasis. She also had a blood clot on the CAT scan of her lungs. So for this patient, we drained 1 liter of fluid from her lungs with a needle and sent it for testing. And here, like I think you all suspect, we worried about cancer, but we would need to do an exhaustive search to confirm what kind before she could be seen at Princess Margaret Hospital, our cancer center. Finally, we started a blood thinner for her lungs and told her all about what we thought it would be. We admitted her for stabilization and workup and diagnosis of what we felt to be a new stage 4 cancer. So you might think that these stories are rare, but these 2 patients whose details have been changed slightly for privacy are really stories of patients that I see and take care of frequently on a weekly basis on the internal medicine wards. So these are the types of patients we see, and this is what we do. So who we are. I'm not sure if anyone remembers the television show Dr. House. It's getting old now, but when patients ask me for the one-liner about what internal medicine physicians do in simplest terms, I tell them we're like Dr. House, but nicer. Because we're experts in diagnosis. We're often the team our colleagues go to when they can't figure out what's going on. But above and beyond diagnosis, we manage and provide ongoing care for these patients as well in hospital. We're also teachers, training the next generation, not only for our own internal medicine physicians, but we teach the foundational residency curriculum for all medical specialties. For example, every cardiologist and respirologist and gastroenterologist, really all of the ologists, to name a few, all of these physicians started out as an internal medicine resident in our program. We're also healthcare system innovators, in part because we are all frontline hospital physicians. We all provide at the bedside care. We see and experience on a daily basis the challenges of our system and are perfectly poised to see the opportunities for change. Last but not least, we're advocates, particularly for those who don't have equal access to healthcare and can't advocate for themselves for many reasons. So to start with some numbers, our team runs the largest inpatient service in the hospital by far, meaning we take care of more patients admitted to hospital at any given time than anyone else at UHN. And in reality, it's actually far more than our allotted number of beds, which is 200. On an average day, for our 200 scheduled beds, we care for 270 patients. I actually checked yesterday and it was at 276. But no matter what, if you need our care, we will never say we're full. But what does 270 patients mean? And what more can I tell you about our patients? Here's what it takes for internal medicine to see and take care of a patient up front. We take a history of symptoms, every detail about what brought them into the emergency department, just like I mentioned for the 2 patient stories. We ask about medical history, multiple conditions, find out what multiple conditions are treated by their outpatient physicians. They're usually things like diabetes and high blood pressure, but they can be anything. Many of our patients are complicated patients known to UHN already and come here because this is their home hospital, because they're oncology patients who are sick from their cancer or sick from cancer therapies, for example. They might be known to the liver program or the UHN heart function clinic, waiting for the right time for an organ transplant. And some, like Mr. A and Ms. B, don't have a diagnosis yet when they arrive, but need one. So I mentioned that the average patient is on around 20 different medications. And so we think about drug interactions and whether I need to stop them or adjust them based on their current illness and their current presentation. We do a head-to-toe physical examination. We order lab work and x-rays and CAT scans and MRIs and do bedside procedures like I mentioned. And after all of this, we put it all together and we think. We come up with a provisional diagnosis and together with the patient come up with a plan of care. Once admitted to my service at the hospital, patients will stay on our wards for 1 or 10 or 30 days or more if needed. They stay for however long it takes to make them better. And then that was for 1 patient. To get an idea of scope, please multiply that by 270 patients in hospital every single day. The second point of this slide is that patients come from well beyond our downtown catchment area. as you can see from this heat map. Patients come from all over the province and sometimes all over the country to receive care at UHN. And it's GIM that takes care of 270 of these 270 patients of these patients on any given day. Because our service is by far the highest volume service at UHN, we see the most patients. We see by a factor of 5 the highest volume of patients compared to other services. When you do the math, this works out to getting almost 2 requests every hour on the hour, 24 hours a day, to care for a new patient on our service. I think maybe not everybody knows that we also have a large outpatient clinic, mainly housed at Toronto Western Hospital, where we care for over 150 clinic patients a week, often within 24 hours after they present to the emergency department, but can be safely discharged home, provided they have close follow-up. And so in this way, we use the clinic to offload the pressures of high volumes in the emergency department. We also have a roaming internal medicine consult service, this icon here with the little man and the stethoscope. And this internal medicine consult service is kind of like an on-call phone a friend service for our surgical and psychiatry colleagues. Sometimes our surgical colleagues need expert medical opinions for a patient that may have, for example, post-operative chest pain or kidney failure or a host of other multi-system conditions that we're happy to see and well poised to take care of as well. We're always available. There's always someone on call from our team 24 hours a day, and we're always happy to help. A critical point here is that the internal medicine service interacts with essentially every single department and function at UHN. And so how we're functioning impacts every other service in hospital. So UHN internal medicine physicians are quaternary care specialists. And what do I mean by that? UHN is a quaternary care center, which means that our hospital provides advanced specialized healthcare services that few other hospitals can provide. For example, organ transplant or hemodialysis. And because of this, our patients are even more complex than in a typical hospital. So one way to conceptualize internal medicine at UHN is really as this term we've adopted called quaternary care specialists. To elaborate on this a bit more, we have expertise in diagnosis. I mentioned Dr. House already. I mentioned how our colleagues come to us when they need a diagnostic thinker, a problem solver, or a detective. Our personality type is someone who will cross every T, dot every I, and will leave no stone unturned. We're skilled in the acute, the complex, and both the rare and the common. We have not only depth, but breadth of clinical expertise. We are just as comfortable taking care of an acutely sick patient as well as a patient with several chronic conditions that need managing, including diabetes, heart failure, hypertension, stroke, heart attack, liver disease. We're comfortable with all of it. And because of this, we take a truly personalized care approach to each and every patient. Patients are more than the sum of their parts, and it's our job to put all those parts together and see the patient as a whole. And it's not just the doctors. I mentioned before that because our patient population is so varied, it truly takes a village of nurses, physiotherapists, physician assistants, and social workers, to name a few. Our entire GIM team at UHN is truly among the best in the hospital by necessity. We are also excellent teachers, and we are among the best in the world, in my opinion. This is one of our chief residents, Dr. Nikita Singh, leading a cardiac arrest simulation, because another little known fact about us is that it is our team that carries the code blue pager much of the time, the first responder pager for anyone in hospital who suffers a cardiac arrest and requires CPR or defibrillation. And so this is one of the many skills that we teach our trainees. This is a bit of a busy slide, but the two main things I want you to know is that all subspecialty physicians begin their training with us in internal medicine. Obviously, all of these specialists, including internal medicine, but also cardiology, respirology, and endocrinology, go on to do amazing work in their fields. But all of these specialties begin in internal medicine, and every one of our faculty members is a teacher for this foundational residency program. You really can't be a general internal medicine specialist here unless you're an excellent teacher. We have our own education-focused research institute at TWH. It's called the Hoping Kong Center for Excellence in Education and Practice, or CEEP, and it's run by Dr. Rodrigo Cavalcanti, who's this top right in the little box here, right here. This research institute was made possible a decade ago by a generous donor and founded by one of our most senior, now retired physicians, Dr. Herbert Hoping Kong, who was the original Dr. House and who continues to be a wonderful mentor and inspiration for many of us. A small example of this type of knowledge translation work that we do includes work by David Frost on the best way to use digital medicine to help other doctors by setting up a Ask a GIM Specialist email consultation service. Hospital care for patients who use drugs. Why are patients with addiction so difficult? This is work by Dr. Laura Rogers in our division. She does work to better understand how to care for patients with substance use disorders, which is a growing population and an unfortunate legacy of the pandemic. And we share practical and relevant questions regarding, and relevant knowledge regarding clinical care. In this example here, this is Dr. Kevin Venus's work on whether positioning a patient face down actually helped improve the oxygenation of patients with COVID-19. This is the type of research that we like to share. And then we've published many, many brief case communications on very timely topics from the front lines, such as how to diagnose long COVID, monkeypox, hyperferritinemia, which is a fairly common lab value, and modern day scurvy and how to think about it. So far, I hope I've been able to convey the heart and the hustle that my team shows when we show up for work every day as frontline clinicians and as teachers. But next, I'd like to describe how we are leading the way in health system innovation. So when we talk about health system innovation, what we're really talking about here is how to make things better for patients. Everyone is aware that our healthcare system is complex, under a lot of strain, and far from perfect. Because internal medicine physicians play such a large role in the hospital, we see the system's flaws firsthand every single day, and we're frustrated by them too. But it means that we also see the opportunities. I'd say our specialty is actually perfectly poised to lead the way in health innovation. Our system needs efficiency, sustainability, and cost-effective solutions. We need to leverage virtual care and embrace technology. We need to always be thinking about the patient experience and timely access to care for everyone, everywhere. In short, we need to be forward-thinking and always be deploying innovation, ultimately to improve the care for all patients. Many of our team members are health systems researchers, and as I mentioned already, we're the central hub of a very complex hospital ecosystem. But if you create innovation and new ways of working within internal medicine, it will quickly permeate into all other functions and specialties UHN-wide. That innovation will become part of the way of working within the hospital because of our huge footprint in the hospital and because we work so closely and impact all other functions and specialties. Here is just a handful of some of the recent published research by our team. Imaging delays. Imaging is one of our mainstays of diagnosis: CAT scans, MRIs, ultrasounds, and even as inpatients, we wait for tests too long and we need to do better. Exploring the patient experience of patients with limited English proficiency. Our colleague, Dr. Shail Rowell, does incredible work on the patient experience and how the health system is not as accessible when English is not your first language. Especially in a city like Toronto, her research is critical to provide best care for everybody. Dr. Lauren LaPointe-Shaw does work on virtual medicine, and in this study, she suggested that virtual walk-in clinics, at least, might have the unintended consequence of actually pushing more patients to seek emergency care, which is far from ideal and not the goal. But this is exactly why we need to do this kind of work, to figure out how to best harness virtual care. Principles for clinical care of patients with COVID-19 on the medical units. When COVID-19 first hit, our Toronto Western internal medicine physician group got together, rallied quickly, and via Twitter communicated with frontline physicians in the hardest hit cities in Europe, and swiftly put together a rapid communication on clinical management and how to best set up a safe and effective COVID-19 ward based on what these other physicians were doing, who were a couple of weeks ahead of us in the pandemic. Finally, raising the bar for patient experience during care transitions in Canada. Dr. Karen O'Kranick's paper, whose work on clearer language for patients on discharge papers, showed us that something so simple and so obvious in many ways can make a huge difference for our patients. You know, our research has global reach through affiliations with leading research institutes and our own innovation think tanks. Several of our researchers are affiliated with leading research institutes like ISIS or the Wilson Center. But even within our division, we've created our own in-house research institute or think tanks. I've mentioned CEEP already as the academic engine that drives all of our medical education innovations. And our newest venture, our Health Quality and Innovation Hub, which just launched last year, thanks to another incredibly generous donor whose belief in our team's critical role in improving the healthcare system through innovation, we're incredibly grateful for. And then lastly, just checking the time, I wanted to take a moment to talk about COVID-19. Not to dwell on the past, but this was a profound moment in time for our team. If you recall, the early days of the pandemic were really scary. In 2020, with 24 hours notice, I remember clearly being asked to start our first COVID-19 ward. At the time, my girls were 3 years old. There was no vaccine. And if you remember, the entire world suddenly went on lockdown and no one knew anything about this new disease. And at the time, we didn't even know how to treat it. It was terrifying. But I said yes, because our patients needed us, and whether or not we were ready, they were coming into hospital. So I said yes, and with zero hesitation, so did every single member of the internal medicine team at UHN. Shoulder to shoulder with critical care and the emergency department, we led the hospital's pandemic response, and that's not an overstatement, sorry. I remember walking to work that first week. The city was quiet, and even the busiest place on earth, the hospital where I worked, felt quiet as things ground to a halt for this brief period that was essentially the calm before the storm. And then it came, and it didn't go away. In fact, COVID kept on coming on and on in waves, and each wave was a little different. Things got a lot better with the vaccine. That was something we were incredibly grateful for, because it was a game changer for working on the COVID wards. We were no longer terrified of getting sick at work or bringing this virus home to our families. I remember I temporarily at one point even sublet an apartment with a physician friend because I was worried about going home and bringing it home to my family. But I wound up unable to do that. I missed my family too much. It seems extreme now, but you have to remember that this was in the early days of the pandemic. And so we did it, and we continued to do it for 3 years. We basically got to work. We started to get really tired and burnt out about a year into it, around the time of Delta wave, which was the wave characterized by the highest transmission rate pre-vaccine for the general public, which resulted in a huge, overwhelming tidal wave of hospitalized patients, mostly those who did not have the privilege or financial means to self-isolate. Eventually, we needed help. And so here's the part of the pandemic where we recruited and trained our colleagues outside GIM to also become redeployed COVID-19 physicians. My colleagues and friends, Dr. Ryan Luther and Allison Lai, among others, held boot camps for our fellow physicians to prepare them for redeployment. We put together guidance documents and clinical guidelines based on the ever-changing protocols as new therapies emerged for COVID-19. And eventually, this became our new normal. But it was always GIM from the very beginning, taking care of the vast majority of UHN patients with COVID-19. When I look back to those first few weeks, I think COVID is actually what gave me the push to step into this leadership role, because I could not believe how much heart and grit my GIM colleagues had throughout the worst times of the pandemic. And I think the experience highlighted for me just how proud I am to be an internal medicine physician. For all of the reasons that I mentioned before, our comfort with uncertainty, our comfort with acuity, and our ability to care for any sick patient, internal medicine was and is the perfect team to lead the pandemic response. And while I'm glad things have settled, in fact, we finally closed our COVID-19 ward on March 31st, I think it was, about 6 weeks ago. And I think what I'd like to share really is that this experience had a profound effects on everyone, but also our team. And we continue to advocate relentlessly for equitable access to healthcare. We will never turn anyone away who needs our care. So many of our patients have medical conditions that are undertreated or go too long without receiving care due to concurrent mental health issues, addiction, and other social circumstances that are far beyond a patient's control. You know, we talk so much about embracing digital health, but we need to recognize that many patients can't even afford a phone or use a computer. We not only advocate for individual patients, but physicians like Dr. Shail Rowell do scholarly work in this area and advocate for those who can't advocate for themselves. And we are extraordinarily proud of that. So why does this all matter? In short, because we owe it to our patients. To go back to our patient stories, Mr. A had fulminant liver failure. He was worked up and treated for multi-system disease related to this liver failure, including infection, bleeding, and renal failure. And after 18 days of caring for him in our service, he received a liver transplant here at UHN. Ms. B had a complicated course in hospital. She needed a larger tube, a chest tube inserted into the fluid around her lungs to help drain them, and we had a lot of difficulty with that. She required a biopsy of a breast lump that we found that she didn't even know existed, and she needed coordinated care, and it was our job to do all of that to expedite the results so that she could get to the right Princess Margaret Hospital oncologist and urgently start treatment. She was often tearful, mostly worried about her children. And 9 days after admission, we were finally able to stabilize her, confirm diagnosis, and were able to get her to Princess Margaret Hospital to start urgent chemotherapy. The truth is, not every patient will need an organ transplant or the latest cutting-edge surgery, but every single person in this room right now, or someone that they love, will need the expertise of an internal medicine physician at some point in their life. Finally, our team is a critical part of the solution to help build a better healthcare system. We have a vision for GIM that includes expanding our outpatient clinic. The Toronto Western Hospital sees so many patients, but it could see so many more. And in this way, offload our most overcrowded departments in the hospital, like the emergency department. We need to harness virtual technology in medicine, not just for patients, but to help other providers. We really need to help out our family medicine colleagues. So with initiatives like Dr. David Frost's e-consult service, we can do that. And with every single innovation initiative that we launch, we need to consider and advocate for equitable access to care for all. We also see value in expanding new models of other types of care, such as short stay units, as another way to offload the patient volumes crisis. And in the bottom left-hand corner, one tremendous gap in care that I'm really passionate about, and I see time and time again, and I used it as an example, is how much uncertainty and how long it takes to diagnose diseases such as cancer in the community. Too much time that patients can't afford to lose. I think GIM is the perfect specialty to take this on, to become the Mayo Clinic of the North, so to speak, and create a rapid cancer diagnosis center and really lead the way. It's what happens before our patients become patients at Princess Margaret Hospital. This is where we can play a huge and tremendous role. We also need to continue to create programs that help get patients home faster and keep them well longer, with transitions of care initiatives to prevent readmissions. One of the examples of this would be our new inpatient addictions consult service that Dr. Rogers is setting up. And we need to continue to invest in and grow our innovation research institutes, both SEEP and the Health Quality Hub I spoke of. Finally, we must never forget all the lessons that we learned from COVID-19, because we have to be ready once again to take swift action if and when the next pandemic hits. And these are the things that we dream of doing, and this is our vision for GIM. Lastly, on behalf of my entire team, I want to thank everyone for being here today. Thank you for letting me share a bit about this team that I'm so proud to be a part of. I appreciate the opportunity to speak about who we are, what we do, and why it matters to us so much. And as we look towards designing a better healthcare system, I recognize that we couldn't do what we do without your support. Thank you.
Wow, Dr. Liu, what a terrific presentation. Your passion and your compassion really came through in that. And, to be an incredible physician is one thing, but, to also be one that shows compassion and can empathize with your patients really is truly a gift. And I think that we are very lucky at UHN to have you leading our GIM team and exhibiting that to the rest of your team. So thank you for your time. It's also great to hear, what's, already happened, what your team has made possible, and, with the ultimate goal of enhancing patient care. And, it's incredibly inspiring to hear, what you have planned for the future. So before we get to our slide of questions, I do have one sort of quick question, just in follow up to sort of the future piece of the team and what you see for the GIM division. Of course, this comes back to donor support, and, you've listed some things that are certainly priorities, but if you had donor support right now, what type of sort of immediate impact could you make, and what would be sort of your top 1 or 2 priorities that you would want to move ahead with right now?
Great question. I think I did address it a little bit in my last slide, but I think the 2 big things, our 2 top priorities are growing and building our ambulatory care clinic. Our Toronto Western Hospital Clinic can expand. We have this amazing team that sees so many patients, but if they had a little bit more bandwidth, a little bit more infrastructure, a few more resources, we would probably be able to double the number of patients that we see. And then secondly, I think investing in our innovative models of care research, because we are at the bedside, in the moment, working in the system every day. We're constantly implementing and trying new things. Our inpatient services, any of these different models of care that we just try, that we implement and study and research, because our goal here for much of what we're doing is to help with efficiency and flow in the system. We have a patient volumes crisis, and we really need to offload the inpatient footprint in the hospital. We have so many patients need care, and as our patient demographic ages, it's really only going to get worse, and we have to plan for that. And I think these 2 initiatives would help offload that footprint in the hospital and help address the hallway medicine problem.
Yeah, no, that's great. I appreciate that. Okay, so let's get to our audience questions.
Okay.
I'll bring up Slido. Okay, let me just make my screen bigger here so I can read them. Okay, so from Montana Skirka, I'm curious how you view managing the mental and emotional health of patients as part of this patient-centered care approach. I'm also interested to hear how managing the mental and emotional health of the healthcare team is included in this. We must heal the healers to be all well as a society.
Okay, so a two-parter. Okay, so a great question. The mental and emotional health of patients and really putting yourselves in a patient's shoes is critical. And I like to think that every patient that I have is, if they're not someone's mother, they're someone's sister, or they're someone's brother, or they're someone's father, or they're someone's friend, or they're someone's child. And a friend of mine and one of the members of my team, Dr. Richard Dunbar-Yaffe, just told me this literally yesterday. He tells his trainees, you have to remember that all the patients we see are having the worst day of their life when we see them. For us, it's our job, it's our work, it is a calling, but it's our job, and we're healthy enough to be there and contribute. For them, they're in the emergency department. They've lost a lot of control. You can lose your house, you can lose your car, but they've lost their health. And if you remember that this is probably the worst time of their life that you're seeing them, it helps keep things in focus as you try and care for them. And then in terms of managing the mental and emotional health of the healthcare team, that is an excellent question. I'm not going to lie, this job can take its emotional and physical toll on all of us. I just described in maybe too much detail about our experience during the COVID-19 pandemic, but what I would say is that we manage it as a team. I have the most incredible colleagues beyond the physician team. I mentioned our allied health members, our pharmacists. I'm going to miss them because there's so many. Our social workers, our nurses, our incredible nurses. We all banded together. We were all in it together. We all know how to do more with less and be creative when times get tough. And I think the best path forward for us was always recognizing that as tough as it sometimes might get for us, it's worse for the people we're caring for. And so those are the people that need our help.
Wow, that's quite a perspective to carry with you every day. And, the story that you told about COVID was, again, I've heard a lot of stories from a lot of, staff at UHN, and it continues to just break my heart and also be so incredibly inspiring, what you and your teams had to do, and that you just got up and you did it, and it was no questions asked. And, so again, just thank you for, what you and your teams have done. Okay, our next question. So what is the most challenging aspect, again, another two-parter, and I'm going to add a third. What is the most challenging aspect of your work? What are you most hopeful for? And what do you love the most about your work?
I think one of the most challenging aspects of my work, I touched on a little bit, is that it's very difficult not to take home with you at the end of the day. And everybody struggles with work-life balance, but sometimes there can be an incredible heaviness of the responsibility that we bear for our patients. But what is also the most challenging aspect is actually what makes this job so amazing, and why it's what we are passionate about doing. You can make a real difference in the world, and I think just being mindful of that is what keeps me on track. But yeah, some days it can get heavy, but I think we always look towards the future and really know that, every day I can say that I've done my very best to try and help somebody who really needs our care. And this is what I'm most hopeful for. I want to continue to do this. I want to use this incredible opportunity I've been given to be the leader of, honestly, the world's best team of physicians, and look to the future.
And what do you love most about what you do?
I really like the people. I like the patients. I like the patient stories that I hear. I like like being responsible for teaching and training residents. It really is the best job in the world.
Love it. Love that answer. Okay, are GIM doctors prepared for another healthcare crisis like COVID? What kind of things has the hospital put in place to ensure we are in a better position to take it on?
I think we are. I think we came through to the other side, and I think that we learned a ton of valuable lessons during COVID-19. If you look back, nobody even knew what Zoom was in 2019, right? And so number one, we are much more well equipped to respond to things virtually. We are much more mindful about thinking about things like transmission of disease should another pandemic hit. I know we have pandemic preparedness protocols at UHN. And so the hospital is really invested in taking the lessons that we've learned from COVID-19 and doing all that we can to be prepared so that next time, if and when it happens again, we know what we're doing.
Mm-hmm. Yeah, no, that's great. How do you manage the patients who have multiple complex health and physical concerns, such as homelessness, mental health issues, lack of community support systems, etc.?
I think with my previous response, I might talk about how it takes a village. I know that as a physician, I can do a lot of things, but I can't do half of what our incredible team can do, what our social workers can do, what our nurses can do, what our clinical nurse specialists who specialize in mental health can do. And we need to really leverage and use all of the members of their team. Everybody needs to work to their, sort of maximum in order to come together to take care of all of these patients. And part of what our role is as physicians is to be the advocates for these patients, to never let people forget that health is not equally accessible for everybody. And it's not something that's just automatically given to everybody. We have to fight for it.
Okay. What is the greatest need in your department?
I think we need resources and support to be able to handle the ever increasing patient volumes. And so that's what I mean when I say support for our clinic, both infrastructure, getting us up to speed in this century in terms of, throwing away our fax machines and having all of the digital technology that we need, and support for the resources to really study and continue to do all of the innovation research that we do.
Yeah, fair. Okay, our final question. Is your service available to only patients who go through emergency, or can there be referrals to you from general practitioners?
As an inpatient, to get admitted to our hospital, the typical pathway is to go through the emergency department, the whole concept of unplanned care that I mentioned in the talk. But we do accept referrals from general practitioners, absolutely. Right now, we don't really widely advertise it because the Toronto Western Hospital Clinic, which is our largest clinic, doesn't have the capacity or the bandwidth. One day we hope to. We do accept referrals, but I would love to be able to say that we are resourced well enough to stand on top of every rooftop in every building in Toronto to say, like, please send your patients to us, but we need help.
Yeah, fair. Okay, well, that brings us to the end of our session. I can't believe almost an hour has flown by. So thank you to everyone for all of your questions. Thank you again to Dr. Liu for your time, energy, your insights, your passion, your compassion, your leadership. As I mentioned, I think we are incredibly lucky to have you leading our GIM team. So thank you. I hope everybody at home has enjoyed today's behind the scenes presentation. It's so important to us at the Foundation that you have the opportunity to discover how your generosity fuels so much great work and incredible physicians like Dr. Liu, and the impact that you're having on people's lives every day. So our next behind the scenes event will be held in the fall. Please keep an eye out for the invitation. For those of you who are so inclined, a recording of the presentation will be available on our Foundation YouTube page should you want to view it, or perhaps share it with some friends. Thank you all once again for being here. Stay well, and I hope to see you again soon. Have a great night.